Welcome back to session 2 of Virtual Transplant Journey 2022. We're excited to recognize our sponsors who have made this event possible. Please give your attention to this short video provided by Trio National.
On behalf of Trio National, congratulations, Michelle and Marty Marin and your Trio Maryland chapter for putting together this fantastic conference adapted for the restrictions of pandemic year past. Great work. Anybody else would like to join Trio in making things like this happen? Go to our website at trioweb.org and sign up. You can make a big world of difference, just like Trio Maryland is with that kind of leadership.
Please remember, you can post your questions in the Q&A tab, and we'll share with the speaker after the presentation as time allows. Dr. Kristen Bybee is a board-certified dermatologist whose clinical practice is focused on the care of solid organ transplant recipients. She is also board-certified in micrographic surgery and dermatologic oncology with expertise in skin cancer management. Please join me in welcoming Dr. Bybee as she shares insights on dermatology and cancer prevention. Dr. Bybee?
Thanks, Michelle, and thank you guys all for joining my session today. I recognize a few of the names in there, and it's my pleasure to share some information to you about a topic that is near and dear to my heart. So let me get my slides pulled up. Okay, so this is the slide that was actually given to me last year as the format slide to use for this talk, and it actually worked out well that I was having trouble transitioning my slides to the new ones because this picture of this woman has a lot of dermatologic findings that of course caught my eye. And as you can imagine, those of us in dermatology, when we walk through the grocery store, we are actually looking at the other people in the grocery store, and we see these things. So I want to show you what I see on this woman, which is some skin findings, seborrheic keratoses, which are benign spots, not anything worrisome, but she also has lentigines. Those are the sun spots. Often this is an indication to us that her skin has seen a fair amount of sun over the years, as are the wrinkles. The wrinkling also is the effects of the sun. And then she does have evidence of what we call actinic keratoses, or these are in that pre-cancer family. So I thought it was sort of interesting that the stock photo would have some nice dermatologic findings. So I'm going to talk to you today about a number of things within the skin world. And I don't have any financial relationships with any of the companies or products that I am discussing. The things that I have at the end that I buy for my family, I purchase. I also have some photos in here that are of patients that I have treated. And I just want to make you all aware that some of the photos are from publications, but some are my patients, and I could only do effective teaching with the generosity of patients I have seen, allowing me to share their photographs for educational purposes. So one thing that I want to highlight, because this has become more and more important as there has become more diversity in transplantation and more of an understanding of the differences between different skin types in dermatology and different races as to how medical care is being conducted. A study by Christina Chung and her colleagues in Philadelphia and at a few other centers wanted to know what was the difference between races, the patient's described race, and what kind of dermatologic conditions they were having after transplant. So these were all transplant patients. And I think what you can very quickly see is that white patients have the majority of the malignant and pre-malignant lesions. So we will be talking about skin cancer as a risk post-transplant today. And that tends to be a condition that mainly affects patients who are white. Now, if you have fairer skin, then you're more likely to get skin cancer to begin with, regardless of whether you're a transplant patient or not. But there are other things that I find to be interesting, which is that infectious diseases and inflammatory diseases of the skin are at a higher rate in patients with skin of color in races other than white. So keeping that in mind as we go through, I am going to show pictures of different conditions and different skin types. I think, oftentimes the transplant team is very quick to have you come see us in dermatology for a skin cancer screening exam, which is an important component of post-transplant care. But we do want to be mindful that not everybody carries the same risk of skin cancer, and we do stratify our recommendations based on your risk. Okay, so I'm going to start out and talk about things that I don't consider worrisome, but can just be very annoying that tend to happen in all patients, but with a predilection towards post-transplant patients. Then I'm going to move on and talk about the things that are worrisome and annoying, and then a little bit of prevention and save some time for questions. So starting off, I've laid this out as what sort of timeline after transplant we tend to see these conditions. And I've put the asterisk besides not worrisome because I want to make everybody aware that this means not worrisome to me as a physician. That doesn't mean it's not worrisome to you as a patient. There are plenty of things in medicine that we don't get too worried about, but can be troubling to you. And in dermatology, a lot of that has to do with the appearance of them. So there are many things that I'm going to talk about here that we will treat, not because we are worried about them, but because it would be nice to get rid of them for your appearance or your self-confidence or other reasons. I just want to make that distinction. So the first thing, and many of you that maybe have had a transplant may have experienced this early on, is acne. So even patients that haven't had acne for even their teenage years, sometimes in that first few months after transplant, they get flares of acne. And a lot of times this is related to the high doses of steroids. Now, patients that have conditions that have required high doses of steroids pre-transplant to keep their condition under control have maybe experienced this as well. So here's an example of the type of acne that we see related to steroid. And unlike the acne that you may see on a teenager, where you're seeing some old things, some new things, and some things that are coming up, it seems like with steroid acne, it all blossoms at the same time and you're just covered in these little bumps. And so, this can be very worrisome to the transplant patient. You've made it through this procedure, you're home recuperating, or you're maybe still hospitalized recuperating, and all of a sudden a new rash, right? There's a lot of medicines that you've been started on during this time. And so it's completely reasonable to consult with us in dermatology if you're concerned about this, although many transplant teams recognize this as an early complication and will go ahead and treat it. We usually use standard acne regimens to treat this. And typically, as the steroid is able to be weaned, we are able to get you off of the treatments and the skin does just fine. You also can get these acneiform or acne-like eruptions. Here you're seeing it in two different skin types. So you can appreciate in the fairer skinned patient, it's more red looking, whereas in the darker skinned patient, it has more of a purpley hue or brown hue to it. And this is often driven by Squamous. And we have found that we can use oral medicines to help with this condition. And so patients that are being put on the mTOR inhibitors like sirolimus often are getting this, and we are able to treat it, but it usually involves adding another oral medicine and not necessarily just using a topical medicine. Another thing that can be very disconcerting that happens is peeling of the skin. And so usually between the first and third month after transplant, patients will see peeling of their hands and their feet. And sometimes this can be painful. So this again is typically related to the mTOR inhibitor class of immunosuppressing medicines, sirolimus. And again, just like with the acne, I can use an oral medicine that will help with this, especially if it's painful for the patient. So something to keep in mind. Another thing that many people have experienced pre-transplant that really can be annoying are these aphthous ulcers. So typically this is happening somewhere in the first month of transplant and maybe even lasting up to 6 months. So we know what these are. They're canker sores. They can impinge your ability to eat. And again, we blame these on the anti-rejection meds, but here it's not just the mTOR inhibitors, but also tacrolimus and cyclosporin, the calcineurin inhibitors, and mycophenolate, the cell cycle modulator. So this is, really running the gamut of immunosuppressing medicines that many post-transplant patients are on. Fortunately, supportive care using a steroid paste that can be put inside the mouth on these can be very helpful. Just like we get these in the mouth, they also can happen in the groin, in the genital region, and in the perianal region. So we try to keep a very close eye on these. They're not worrisome, they're not harmful, but they are worth evaluating because there are other things that can look like aphthous ulcers that really are something else. So again, an aphthous ulcer would be something annoying, but worth an evaluation for treatment options and to ensure that it's not something more worrisome. And here's the thing that I probably talk the most about in my clinic with the early pre-transplant patients, which is issues with hair. Many patients lose their hair after transplant, not to the point of being bald, but they have massive shedding events. And this is a well-established phenomenon in medicine that you would have shedding of your hair. Usually it happens about 3 months after a big event that happens to your body. So a big stressful event like having a new organ put in, but also some of the medicines can drive hair issues as well. So the shedding event is actually called telogen effluvium, which sounds a little bit like a spell from a children's story. So telogen effluvium is where your body has been actually holding on to hairs that it would normally shed, and for some reason puts all those hairs into the shed phase when only maybe 1/3 of them are supposed to be in the shed phase. So it's typical for patients to lose about 50 to 100 hairs a day. And so you can have upwards of 300, 500 hairs that you're losing a day. And typically what patients tell me when they come in with this is they're just getting clumps and clumps, and their shower is full of hairs once they go to take a shower. And again, this is a phenomenon that we know happens not just to transplant patients. And the good news is that the hair grows back. Those hairs that have all gone into shed phase early, they will cycle just like the bulbs do in the spring. They'll cycle and they will regrow. It's just takes a little while. And so we start to look for the little baby hairs growing first, and then eventually you'll get longer hair. So people do not go bald from the telogen effluvium phenomenon that happens after stressful events. There's other hair loss that can be related though to tacrolimus or to cyclosporin. More commonly with cyclosporin, we're seeing hair gain. And so for those patients, we're using a lot of conventional hair removal systems, whether it be Nair for depilatory cream or laser hair reduction treatments, depending on where it is. And then for patients on tacrolimus that are having hair loss that we're not regaining it, we sometimes need to use topical minoxidil, which is also called Rogaine, which is available over the counter and can be very helpful. Many times I have heard transplant coordinators recommend biotin for patients for hair. I think biotin is an okay medicine to take. It doesn't have a lot of data that it's going to help with the hair in our patients. It's mostly been studied for nails. And I do worry a little bit because biotin can interact with a couple blood tests that are used not routinely in transplant patients, but for evaluating other things. And so I'd be cautious in just universally starting biotin in all patients. There's also plenty of hair and nail supplements out there that that many people have taken, some of which patients report to me they've noticed a significant difference. But others, it's hard to know. I would just say make sure you check with both your transplant team, and then if you're seeing a dermatologist, the dermatologist before you start a supplement, because there can be some interactions and issues with those. So again, you can have shedding events, you can have hair loss related to the medications, and you can have hair gain. Unfortunately, this hair gain tends to be in places you don't want it, like on the face instead of on the scalp for women. So it can be quite distressing and definitely worth considering options to reduce it. And then another one that we see commonly, and I oftentimes am asked to weigh in on because of concerns from the transplant team of new bumps, is this phenomenon called sebaceous hyperplasia. So this is overgrowth of the oil gland, and the data suggests that this is likely due to calcineurin inhibitors. So cyclosporin and tacrolimus, which many transplant patients are on one or both of these, or one or the other of these, some of which are on Envarsus, the long-acting tacrolimus. But as you can see on this gentleman who had a heart transplant, on his cheek, I've circled one. Now the red square is where he had a biopsy for a spot of concern. But this is the spot that's actually the overgrowth of the oil gland. They're not worrisome, they're not harmful, they don't transform into anything. But if you look really closely on this gentleman, I've circled one, but in the next slide, you can see he actually has quite a few on his face. And for many of our patients, this can be quite distressing for them. We do have cosmetic therapies to get rid of them, including putting a little needle in them and burning them, or numbing them and scraping them. And so if it's frustrating to have those, then we certainly can get you set up with the right person to treat those. Unfortunately, because they are a benign spot, typically the insurance company does not pay for them to be treated. Okay, and then another one that can be a little disconcerting is this type of folliculitis that's related to Demodex. Demodex is a mite that lives on our skin. Everybody has the potential to have Demodex. We just think that with the immunosuppression, your body may not be doing such a good job of combating it. They are not globally harmful to you. It's just they can cause this acne-like rash. So you can see in this lady and gentleman over here, it's typically itchy, and it looks like acne bumps on the face. Can be mostly on the cheeks and up here on the lower part of the forehead. This gentleman has it on his upper forehead. The nose is a very common spot. And this woman that is from East Asia descent, you can see she has it on her cheeks, her upper forehead, and a little bit on her nose. So this is what we see under the microscope, is this little mite, and it's usually wiggling a little bit, which can be disconcerting to the patient to learn about that they're carrying this mite. But again, it's not going to get inside your body, and it's not harmful to you, but it can be very annoying to have this. And so we treat this with topical medicines, typically like permethrin cream is a common one to use, but also for some patients, we have to use an oral antibiotic in the tetracycline family, like doxycycline, to help with the inflammatory component that goes along with it. Okay, so now I'm going to move on to the worrisome and annoying skin problems. So the first one I want to talk about is dermatophyte infections, and dermatophyte infections are, this is a yeast or fungus that likes the skin. And so it's manifested in many different ways. It's can be jock itch, tinea cruris is what we call that. It can be ringworm, tinea corporis is what we call that. It can be toenail fungus, onychomycosis, or foot fungus, athlete's foot, tinea pedis. And the reason that it's worrisome to me is not because the infection of the skin is that worrisome. It's that I worry that little micro breaks in the skin may set you up for other infections with things like bacteria, if this is driving you to be very itchy. It also can be quite widespread in our transplant patients. And so we do like to treat that. Now, toenail fungus itself, I usually talk to the patients about what their goals are with treatment, because some of the therapies that we use for toenail fungus Well, the most effective therapy we use for toenail fungus is an oral medicine. And many of my transplant patients say, I do not want to take one more oral medicine. And I think that that's totally reasonable. If the fungus is restricted to the toenail and it's not causing any additional problems, I don't think we need to rush to treat it, especially since my best treatment option is an oral medicine. Topical medicines for dermatophyte infections just are not as effective as we wish they were. So here's an example of a gentleman I saw while he was still in the hospital, and you can see he has this very extensive rash on his back. Almost looks like someone's put tissue paper on top of red spots on him. And this was so extensive in him that we elected to treat it with an oral medicine. He was very itchy from this rash. Over here, you can see on a darker skinned individual that rather than seeing so much pink, you're actually seeing kind of like this white ash looking phenomenon that's happening here. Now, commonly, patients will start putting things like hydrocortisone cream on this, maybe because it's itchy, and that's an anti-itch cream. That's a topical steroid cream you can get over the counter. And hydrocortisone or other topical steroids actually are like Miracle-Gro for these types of skin infections, because what it does is it actually gets rid of the redness. It targets that inflammatory response, so the red goes away, but you're left with just a growing and growing and growing yeast or fungus problem. And so, it's important if you have a rash that's not responding, that it does get evaluated. Here's a little picture of a toenail that many of you have probably seen in your lifetime, a nail that's lifted up with all this thick debris under it that's most likely affected by foot fungus. Now, for me personally, oftentimes with my transplant patients, I actually will try to culture the fungus that's growing under the nails if we're thinking about doing an oral therapy to try to help the nails, because many of you have been on antifungal medicines as part of your transplant journey, whether that be because of what was found on the donor organ or predisposition to other conditions prior to transplant. There's a host of reasons why the infectious disease and transplant teams may have you on a long course of antifungals. And so, if you've been on a long course of antifungals and you're growing something under the nail, I want to make sure that that's actually going to respond to the antifungal that I would want to use. So whereas most patients that come to me that haven't had a transplant that have foot fungus or toenail fungus, I can just off the shelf pick a medicine to use. Often with my transplant patients, I'm recommending that we actually do culture it to see if we can find the culprit organism, because it's not all the same fungus that's driving it in everybody. Okay, the next thing I want to talk about that is in the worrisome category are warts. Now, warts themselves they are very, very annoying, and they're very stubborn, and they are super hard to get rid of. And we absolutely rely on the immune system to help us kick the virus out of the body that is driving warts. But the reason I have warts in here under the worrisome problems is because sometimes things that look like warts could actually be an early type of skin cancer. And I want to show you some examples of that next. Typically, we're not seeing warts in the first little bit after transplant. It's usually after the first year. And you can see the statistic down here, 50% of transplant patients have an issue with warts at 1 year, and by 5 years, it's 92%. And this is not surprising because warts are very common. Warts can involve the hands and the feet, but we also are talking about genital warts. So even if somebody had genital warts as a young individual and they're much older when they get their transplant, it may be that their immune system had kept that wart virus at bay in the genital region, but now that they're immunosuppressed, the warts are now going to come more to fruition. So again, it's important if you notice new spots in the genital area that those do get evaluated. Here's an example of a patient that I had the pleasure of treating when I lived in Pittsburgh. And he had a number of spots on him And this one up here ended up being an early skin cancer. And this one right here, which looks very, very, very similar clinically, was just a plain old verruca vulgaris, which is the medical term for wart. So it can be challenging for us sometimes to distinguish between the two. We obviously want to be very aggressive in getting rid of the skin cancers so that they're not allowed to spread or grow larger. But the warts, we sometimes we will treat these because they can be annoying. We, again, like I said, we don't have to necessarily treat them, but they can spread if we don't. And so typically we try to treat them. Anybody on this call that's experienced a wart before knows how annoying it can be to treat them. There is no, silver bullet that we have out there to help with warts. We have a whole cadre of options that we use, and we really try to tailor that to what the patient is going to be able to tolerate the most, what makes the most sense for their travel distance to get to our clinic, and also thinking about them in general. There is some, here's some warts in a patient with a different skin tone than the gentleman I just showed you. So you can see in darker skin, they can be much lighter, and so they can stick out a lot more. So sometimes they're called to your attention even sooner. There has been some data that vaccination against the HPV strains that drive genital warts may help with warts not in genital areas. So the Gardasil vaccine is targeted against HPV strains that are known to drive genital warts and the ones that have been found to cause cancer, whether that be of the cervix or oropharyngeal cancers. And so it has not become a universal recommendation from us in dermatology for transplant patients to get this vaccine, but certainly worth talking to your transplant team whether the HPV vaccine makes sense for you in the pre or post-transplant state. Okay, so the thing that fills a lot of my surgical time is taking care of patients with skin cancer. There are plenty of my patients that have had skin cancer pre-transplant. There's also plenty of patients I see within their first year that develop a skin cancer. But we start to worry that the transplant is affecting your rate of skin cancer usually after the first year. So we know transplant patients get more skin cancer. I was part of a large study a number of years ago looking at 22 academic centers where we take care of high volume of transplant patients. And what we were able to show is that the incidence of skin cancer in a transplant recipient is 1,400 per 100,000 person years. Now, that 100,000 person years means like absolutely nothing to me. How do I then counsel somebody about their risk? So I went into the literature to figure out what the risk or what the incidence of other cancers that I feel like we have a better hold on. So we know that breast cancer is super common among women, and the incidence of breast cancer is 120 per 100,000 person years. So for transplant patients, the incidence of skin cancer is 10 times higher than the incidence of breast cancer. So that really helped me put it into perspective. And then of course, we know the incidence of lung cancer in people who currently smoke is quite high, but still transplant patients have a much, much higher incidence of skin cancer. I'm not saying this to scare you. The majority of these skin cancers are very easy for us to treat using a host of modalities. I will be the first to say that there is no such thing as a minor procedure when you're the patient, and we recognize that. But most of what we do to treat the majority of skin cancers are our outpatient procedures done in our office and do not require a trip to an operating room. Sometimes we're even able to treat them with topical therapies like creams and ointments, as opposed to using just more destructive methods or cutting and sewing. So this is a couple of examples of melanoma, which is sort of the banner skin cancer that you always hear about and people get very nervous about. It is actually not the most common form of skin cancer by any means. It is a cancer of the pigment producing cells in the skin. And we know that the earlier we can detect it, the better the survival is. It's caused by UV radiation, which you can get from either the sun or from tanning beds. And the thing that is always counseled for patients for these lesions are that they can be, look for moles that look funny. They're asymmetric. The border is funny looking. The colors are multiple. The diameter is huge. And most importantly, they're changing. The other thing that we tend to tell people is to look, if you have 100 moles and all of them look the same except for one, that we want to key in on the one that looks different and try to understand why you made that different looking mole, why the mole might be growing, why the mole might have two colors. So a lot of patients come into my office and say, well, all my moles look the same. And I think it's great that they know what their moles look like. I think it's great that they know where their moles are. But melanoma is not the most common skin cancer after transplant. And so it's not the only reason to come see us. The picture that has the 4-centimeter mark on the lighter skinned gentleman's back, this was a heart transplant patient that I was asked to see. Interestingly, he actually had a spot on his upper lip, which was why I was asked to see him. And in seeing him and doing a skin exam, I found this melanoma. It was quite wide, but fortunately it was quite thin. So he did very well after surgical resection of that. The picture on the bottom is just to show you that melanoma also can exist on places that probably have not seen much sun at all. And this is an example on a darker skinned patient of a melanoma that is on the bottom of the foot. So any of you that have been to a dermatologist, especially if you've seen me, know that the bottom of your feet and between your toes gets looked at quite closely. That's because we know that there, even though the predilection is for sun exposed areas, you can certainly get these cancers in sun protected areas as well. This is the type of cancer that's the most common in transplant patients. And in non-transplant patients, it's actually the second most common. So squamous cell carcinoma. So this is a cancer of the keratinocyte. The keratinocyte is the cell that makes the majority of your skin. No matter the color of your skin, most of your skin is made up of keratinocytes. So this happens with sun exposure and acquiring mutations. And then if the cancer is in the groin, it's probably related to the HPV virus driving it. Because those are areas that typically are not seeing much sun. These can be waxy or scaly, they can be yellow, they can be red, they could be an ulcer that doesn't heal. Commonly, patients tell me it's a pimple that they tried to pop and it just got bigger and bigger, or a bump I tried to squeeze. So you can see the patient with the glasses on the nose, that like scaly pink spot on his nose, that's a squamous cell carcinoma. And then the person who's pictured down at the bottom, this is on the trunk of that person. This is more of that bump I tried to squeeze look. It almost looks like a little volcano that's formed. So that's also a type of squamous cell carcinoma. I did not include it in this talk, but there's another type, basal cell carcinoma. Basal cell is the most common type of skin cancer in all comers. And the second most common in transplant patients. It tends to also be a bump, but it can also be scaly. It can be pink or purplish. And typically patients tend to make more than one of them. And so again, that's something else that we are looking for on our skin cancer screenings. I'm going to introduce you to a couple people that I've had the pleasure to take care of. This is a 56-year-old man who previously worked as a roofer and had a kidney transplant about 7 years before I met him. Unfortunately, he elected not to have these spots evaluated earlier because these did not all pop up at the same time, and they did not all pop up a couple weeks before he came in. He had had some of them for quite a long time, and I think he just put it out of his mind. So the day I met him, he actually had 24 spots on him that we were worried would be skin cancer. So obviously we can't take all of these off surgically in one go. That would be a lot to put anybody through. So we started to stratify them based on what their risk was in our management. And like some of our patients, he did get exhausted with the managements that we were doing. And I completely understand that. Nobody wants to be in the procedural chair for sure. And he had so many on his face, which we had to address with a longer procedure. So, he took a little bit of a break after we got the first few addressed. And as we moved through the years, unfortunately, though, some of his spots were getting much bigger. Ultimately, unfortunately, one of his skin cancers did end up metastasizing, and he ultimately passed away from metastatic disease from skin cancer, so metastatic cancer. His organ was doing very well at the time of his death. And so he's a cautionary tale to have things checked out. I know as a transplant patient, there are a lot of physicians that are involved in your care. There's a lot of doctor's appointments. There's a lot of blood draws. There's a lot of things that you sign up for when you sign up for transplantation. But just a cautionary tale not to let your skin get out of your focus, because it certainly can become a problem. This is a gentleman who was in his mid-60s and had a lung transplant. He actually came to me for a rash on his head. And I asked him if he had ever had his skin looked at, and he said no. And I said, well, if you look at his skin, he has a number of freckles on that. This is his shoulder looking down from his back on the top. And he had a lot of freckles in the area of his skin I could see. And so I could tell he had probably had a lot of sun in his lifetime. And sure enough, when he took his shirt off, we noticed this is about 1.5 inches or 2 inch, that one that's labeled with the number 3 skin cancer that ultimately was quite deep on him and required a pretty big surgery to get rid of. The one that's labeled number 2 is a different type of skin cancer. We also took care of that surgically. This is a woman that was in her 70s, also a kidney transplant recipient. Interestingly, she was married to another transplant recipient, and he was in fairly poor health. And so she had sort of put her health a little bit on the back burner to help care for him, which we commonly see in spouses or significant others. And what ended up happening is she was allowing many of these spots to grow. This is a common spot for me to see skin cancer on women that are more than 60 or 70. A lot of it, I think, has to do with a lot of sun exposure when they were in their 20s or 30s, because there aren't nearly as many men, I think, that were laying out at the pool or trying to tan their legs as it seems like women were in that era. So she also has a lot of skin cancers, and I also took care of her when I was in Pittsburgh, and she was somebody that we slowly were able to manage the larger ones with surgeries, but then we had some other options to offer her for some of the smaller ones. So just like I talked about the differences based on race of skin conditions for transplant patients, there's also differences in the skin cancer locations. And this is not surprising to us, although I'm glad somebody did the study to show it, because we do know that pigment in your skin can be protective. The pigment can act like umbrellas and can help sort of shield the DNA of the skin from damage from the sun. So the less pigment you have, the more susceptible you are. And the more susceptible you are to sunburns, the more susceptible you are to skin cancer. So this is a study, again, done by Christina Chung and her colleagues, looking at a couple different sites of transplant centers, and basically saying, okay, in the 64 white patients we looked at that had skin cancer, where were the skin cancers? And you can see the majority of them were on the head and neck. Then you had upper extremities, so sun exposed areas. And then from there, the chest, the scalp, the lower extremities, and the abdomen. Contrast this with the patients who are Black that had skin cancer. So that was 9 patients in this group that they were looking at. And only one of those patients had a head and neck skin cancer. The majority of them were actually genital lesions. Now, this does not mean by any means that Black patients are more susceptible to having genital skin cancer. It means if you have skin cancer and you're Black, it's more likely to be in the genitals. And this, I think, speaks to the protection that the pigment provides for you from the sun. And then here in our Asian population, again, majority head and neck, a bit fairer perhaps, of a skin type, a bit less pigment than our Black patients. And then our Hispanic patients, it was a small number, only 4 in this study, but the majority of them were on the lower extremities. So there can be differences in location. And certainly this has informed my practice to make sure that I educate my patients to keep tabs on the genital area, to look at the penis and scrotum, or for women, typically you are seeing the gynecologist for your cancer screening with them through pap smear in the bimanual exam. And so typically I will ask my female patients if they have had any, if their gynecologist has noted any lesions they're concerned about as well. So what are the recommendations for skin cancer screening? The recommendation absolutely depends on the organ you received and your risk of skin cancer prior to transplant. So I do not approach the patient who is 20 with dark skin and has a kidney transplant the same way I approach the 65-year-old who has white skin with lots of sun damage who had a lung transplant. Those are very different patients in my view. The minimum that we recommend is every 2 to 3 years, and I have a number of patients that are on that regimen, but there are some patients that I see every 3 months because they are at high enough risk for skin cancer. If you had a skin cancer prior to your transplant, that's very important for your transplant team, but also for your dermatologist to know, because those patients are going to be at a higher risk. They've already proven that with an immune system, they have made a skin cancer. So now that they have a suppressed immune system, we would anticipate that they would be more likely to make a skin cancer. So those patients tend to see me more frequently than maybe what they would have if they had not had that skin cancer prior to transplant. We grade your risk based a lot on the phototype that you have. So this is independent of your race. This is just you telling us what happens to your skin if you were to go outside without sunscreen. So if you always burn and never tan, one of my partners at Hopkins has this type of skin, one of the other Mohs surgeons. He's covered in freckles from his childhood sun exposure. And if he walked outside, he would just get red. And then the red would go away. And these are the fairest skinned individuals. Typically they have red hair or like a strawberry blonde hair. And these are the patients that we worry about the most because they have the least protection. And then we have patients that burn and occasionally tan, which is a fair number of patients. Tan after an initial burn, but then keep tanning. And then you can see going on burn minimally. And as you go lower and lower, your risk of developing a sun-related skin cancer is lower. Okay, so just a few minutes to talk about prevention. This is something I think that I spend a lot of time talking about to all my patients, and transplant patients probably get the most earful of it, especially when I'm seeing patients in August and September when people have come back from vacations in sunny places and have very tanned skin. This is my son, who's actually much older now. He's almost 5, but this is a picture of him. And this is what he looks like out in when we do outdoor activities. So I have a wide brim hat on him. We use zinc-based sunscreens because that's a physical blocker of the sun. I like that zinc base a lot. It also is great for skin that's more sensitive. And I love UPF clothing because I personally hate the feeling of having most sunscreen on my skin. So I buy a lot of this UPF clothing in long sleeves. The technology of the fabric has gotten so much better that it's very breathable, even on hot days. And it just takes the hassle out of also having to wear sunscreen on that skin if you just protect it physically with clothing. my greatest achievement, I think, right now from a dermatologic standpoint for my son is he thinks that you have to have a shirt on if you're a boy to wear a bathing suit. So he is convinced that the bathing suit shirt is part of the bathing suit for boys, which can make for some interesting conversations when we go to the pool. This is information that's been provided by the American Academy of Dermatology on what to look for a sunscreen. And the ones that I want to focus on are these words. So broad spectrum, that means it protects against 2 types of UV radiation, the UVA and the UVB rays. We know these both play a role in skin cancer. We also know that UVA does a lot of damage to the second layer of skin, and that can cause signs of aging. This says SPF of 30 or higher, which I think is a reasonable recommendation for my transplant patients. I often ask them to look for 50. The reason being that you need to use actually quite a bit of sunscreen to get the SPF that's on the bottle. So if you were wearing clothes and you wanted to cover your face, your hands, let's say you're wearing short sleeves, so it's your elbows down to your fingers, you would need to use 1 ounce, which is a full shot glass full of sunscreen, and nobody that I know actually uses that much sunscreen. So I feel like if we're using 50, but a lower amount, we're probably getting closer to 30 worth of protection. If you're using 30, you might be getting even less if you're not using this full amount. The other thing to look for is water resistant. Now, no sunscreen is waterproof. And so the biggest thing to remember with sunscreen, once you've picked a sunscreen that you like the way it feels on your skin so that you will put it on, is that you have to reapply it. If you're doing something physically active, if you are sweating a lot, if you go swimming and you dry off, you've got to put the sunscreen back on. It does not stay on there. What I think of the water resistant as giving you is protection while you're in the water, but not once you're out of the water and you've dried off and you've rubbed a lot of that off. So again, my picks, I do SPF of 50. I love the mineral-based sunscreens. If you have a darker skin type and you don't like that white sheen that you get from mineral-based, they have tinted ones now that can actually be quite helpful. I have recommended those even to my uncles and my father because they don't like the way the white looks on their face, but they're happy to put the tinted one on. I love the sticks because I think they're really easy to put on the face and you can just rub them in. And I do not use the spray for a couple reasons. There's evidence in some of the spray sunscreens that a chemical called benzene has been found in them, and we know benzene is not good for our health. It has to do with the way the spray is manufactured. So I am weary of that. But the user of the spray, I also worry about because I commonly see people spray the sunscreen on and then they run away and go do whatever they're going to do. The spray is supposed to make it easier to get onto the area, but you still have to rub it in. And I think most of us have probably seen people that have what looks like a spray pattern of sunburn because the spray stayed on those spots, but the rest of the skin didn't have the protection. So I do avoid using the spray. I completely understand the marketing of it and the convenience of having spray, but making sure that you're getting good coverage, it's hard to do that with the spray sunscreen. And then the added concern about using the benzene component in them. Here's some examples of sun protective clothing. Again, these are ones that I have purchased. I have no financial relationship with either of these companies, but I did want to bring up that you don't have to spend an arm and a leg for these things. It used to be that to get this UPF clothing, it was like $100 a shirt, which is totally, unreasonable to ask people to spend that much, I think, on a piece of clothing. But now you can get much cheaper ones, and you just have to make sure that it's been tested and gets that seal of approval for the UPF. I also really like wide brim hats because the ears are a common place for me to operate on. Baseball caps, will definitely cover the scalp, but they provide minimal coverage of the forehead, and definitely they don't cover the ears. And so I like the wide hats. If you can get a 3-inch brim, that would be best. And this one I actually have this exact hat for my son, and it's longer in the back, so it covers the back of his neck when he's out playing, and I like that. Many of you are avid gardeners or avid outdoors people, and certainly getting a transplant should not restrict all of the fun that you wanted to have pre-transplant. It's supposed to be a quality of life operation, and for some organs a quantity too. And so, you know, no one says don't go outside, just be smart about when you're going to be outside, and protect your skin so that you don't end up needing to be in our surgical chairs. Okay, with that, Michelle, I think I'm ready to take some questions.
All righty, great. We have a few. We're going to start with one from Jean. She asks, how effective is photodynamic therapy for AKs and treating SCCs requiring Mohs surgery?
So photodynamic therapy is a mechanism that was developed where we paint a medicine onto the skin. That medicine preferentially is used by precancer cells to activate a pathway in the skin, and then we come back and hit it with a blue light source. And the blue light source basically causes those cells that have taken the medicine up to have little bitty bombs go off in them. And so it's a destructive method where we're not actually doing the destruction, but your body is based on a chemical reaction. Photodynamic therapy has been used head-to-head with other topical things for actinic keratoses in transplant patients, and it's been found to be quite effective. The majority of the studies that have been done in transplant patients, though, on photodynamic therapy are being done in Europe, and they use a different chemical than we use in the United States, and they actually use red light and not blue light based on the chemistry. My preference is actually to use some of the other modalities for actinic keratoses, but I do have plenty of transplant patients where photodynamic therapy has been their best treatment for clearance of actinic keratoses. I don't recommend using photodynamic therapy for invasive tumors. It doesn't penetrate enough. So squamous cell carcinoma, by definition, has invaded beyond the top layer of skin if it's not an in situ carcinoma. And so for those, in general, surgery is my recommendation. PDT, photodynamic therapy, or PDT, would not be as effective as Mohs surgery in clearing invasive skin cancer.
Thank you. Our next question. Does Hopkins routinely refer transplant patients for skin cancer evaluation, or do they wait for symptoms?
So that's a great question. The vast majority of the patients I have seen have been told that they need to be seen by us or a dermatologist in their community within the first year of transplant. Now, I totally recognize that the transplant teams are also telling you a lot of things when you come for those visits. And so sometimes I think the information is conveyed and not heard, which happens. We know in medicine that only about a third of what we say does the patient actually retain. And so, you know, they could be saying it and people could not be hearing it for sure, or they could not mention it because it's not the most pressing thing for that visit. But my experience has been, I see plenty of patients that come to me not because they have anything they're worried about, but because their transplant team said it's a good idea for you to see people for a skin cancer check. At Hopkins, there's two of us that specialize in transplant dermatology, Dr. Manisha Loss and myself. And that is, that's a lot. I mean, many transplant centers don't have a dedicated dermatologist for transplant patients. And if they do, it may be one person. So we definitely have built at Hopkins a consortium of us that will see these patients and really specialize in that.
Great, thank you. And then I think you kind of touched on this. One person asked about, like, after kidney transplant, is skin cancer, will it happen for sure? But I think you kind of touched on the statistics in terms of, you know, there are certain transplant organs that it's more likely than others. And it also depends on your skin, your sun exposure, et cetera. So I think that question you would answer, it's not going to happen for sure, but there's so many variables that.
Yes, there's so many variables on who gets skin cancer. And so yes, I would not say that there's, anybody that I would exclude and say, you're never going to get a skin cancer.
And then the next question was aloe vera gel. Is it safe for skin or not for transplant patients?
Did you say Aldera?
Aloe vera.
Aloe vera.
Yeah.
Aloe vera is fine. Oftentimes, for some patients, they'll say that it's very drying on their skin. And many of my transplant patients feel like their skin has changed significantly after transplant and they don't make the moisturizers as much. So yes, aloe is fine as long as you don't develop a contact allergy like a poison ivy-like reaction to it. But if you're using something for moisturizer, I would recommend you use a cream and not a gel. And I would recommend you use a thick cream for moisturizer instead of a lotion or a gel.
Well, that kind of segues into another question, so I'll ask this one next. A gentleman asked, can you recommend a healthy daily body skin lotion for transplant patients, particularly Black males, if possible?
Yep, so the data suggests that if you use ceramides, creams that contain ceramides tend to give you the most moisturizer. Now, many of my Black patients love Vaseline, and I love Vaseline. So if you can stand rubbing Vaseline on your skin, I love it. It's cheap. It doesn't have to be the brand of Vaseline. It can be petrolatum jelly. But some patients say it's too tacky or sticky for their skin. But I have noticed that in my patients who are Black, they do tend to like the feel of Vaseline, especially on particularly dry areas. But for all comers, regardless of your skin color, Vaseline provides a lot of moisturizer to the skin. If that ointment base or that tackiness or stickiness bothers you, then the ones that I typically recommend are CeraVe and Cetaphil. They both begin with a C. In a cream. It's a jar that you buy, and it's a 1 pound jar. I buy them whenever they go on sale at whatever place I am. That's when I buy them because they can be kind of pricey sometimes. But using that every day. The other key is when you take a shower, don't dry yourself off completely. Put the ointment if you're using Vaseline, or put the cream on while you're still a little bit damp, and just sort of air dry after that. It'll help seal in that moisture. And also, the gentle skincare we recommend, which is not to do the hottest hot shower that you can possibly stand, which I know feels really good for plenty of us, but that does strip oils out of your skin. So you want to do a warm shower, not a hot shower.
Thank you. And we really only have time for one more question. I know there's some others, but I will promise to send them to Dr. Bybee and ask her to answer them directly. The next question was, do you only take patients who are referred by a transplant nephrologist, or can a post-transplant patient make an appointment with you directly?
Yeah, a post-transplant patient can make an appointment with me. All they need to do is identify themselves as a transplant patient when they call. So at Johns Hopkins, if your transplant care is at Hopkins, your chart is usually flagged. So when our schedulers are on the phone with you, then they will see that you're a transplant patient, and they will preferentially actually put you with me or Dr. Loss. If you don't have your transplant care at Hopkins, that's also fine. I see plenty of people that have their transplant care elsewhere. But your chart's probably not flagged as a transplant recipient, so you do need to identify yourself as a transplant recipient when you call, and then that will trigger them to offer you an appointment with me. Actually, the majority of my skin check appointments are only for transplant patients. So, I do see a handful of spouses of transplant patients that when they come in as well, but the majority of the patients I see are transplant. So most of my slots are cordoned off just for transplant patients.
Right. Thank you so much, Dr. Bybee. And again, if you have questions that we didn't get to, I'm really sorry. You are also welcome to forward those to the email triomaryland@ashtonconferenceplanning.com, and I will make sure to get them to Dr. Bybee so that she can answer them for you. Thank you again. Great information for everyone. We really appreciate it. I want to remind everyone that our next set of sessions and our last set of sessions starts at 11:45 a.m. Eastern Time. Please remember to check the event website or your email for the Zoom link for the next session, and we will see you then. Thank you again. Have a good afternoon.